Good morning and welcome to this presentation on electronic health records in the ambulatory oncology setting. Today we're going to be discussing some safety and quality considerations as we work towards improving our electronic health record here at the Massey Cancer Center. I am Carly Viola. I am an infusion nurse here for the Dalton Infusion Clinic. Here at Massey Cancer Center, we currently practice with what can politely be called a hybrid system, but more accurately should be referred to as fragmented, meaning that the way we document, the way we get information and share information is split between both the electronic route and the paper route. Additionally, physicians can write orders and prescribers can access information through the pharmacy in both electronic and paper formats. To add to this problem of fragmentation, nursing can decide between paper, a clinical note, and documentation on the electronic medication administration record, the EMAR, for where and how they document certain interventions. Overall, this creates a very inconsistent pattern and leads to lost information and definitely a decrease in continuity of care. As you can see in this picture to the right, it's fragmented, it's pieced together, it's not all the information is where it should be, and that's what we really are seeing here in the ambulatory care setting. And there's quite a lot of risks involved in having such a fragmented and broken system for patient documentation. The major gap in patient safety is time. And that time is expressed in a number of different ways. For example, the time it takes to find a correct record for a patient, the time it takes to obtain essential information such as vital signs and a medication list, and also the time and the redundancy of double or triple charting. This wasted time leads us to high expenditures in employee costs that is wasting our resources and could be otherwise used much more efficiently. As far as our patients are concerned, this waste of time and vulnerability of incomplete information will ultimately lead to a delay in diagnosis and treatments. Time is a very precious and finite resource, and we as clinicians and as administrators and as leaders in this cancer center, we must all consider an endpoint of time saved to be a really strong endpoint for any change initiative in the healthcare setting. Fortunately, here at Massey, we have a really strong foundation to succeed in change. That it already exists within our institution through our administrative hierarchy. We are a health system that believes in the shared governance model of change. Take this picture, for example. There are 3 leaflets, each equal in size. 1 representing managers, 1 representing leaders, and 1 representing staff. They are all expected to contribute an equal amount of effort and input into promoting changes. Without input from staff, assumptions are made, and those assumptions lead to poor understanding of a change and very high employee attrition. When we incorporate staff members into the change, there's a lot more buy-in and a lot more satisfaction for those staff members as they see that change implemented and how that change affects their day-to-day work and, of course, how it affects our patients' outcomes. In addition to such a strong culture of change in this health system, we already have an existing electronic health record that captures a lot of the information that we need for safe patient care. Instead of trying to take on the financial and technological burden of creating or using an entirely new electronic health record, we really should work with our information technology colleagues to improve the safety, quality, and usability of our existing program. Moving forward with a strategic plan to help make improvements to this existing electronic health record is with a goal of optimizing safety and quality of care. First things first, we must transition all chemotherapy orders into an electronic plan. And for that, we would want a threefold system for safety, checks, and balances that includes physician, pharmacy, and nurse. The first step of this plan is that physicians write orders in an electronic format. Orders are then verified by a pharmacist, and they are then activated by a nurse. All the members of the medication administration process are involved. They have buy-in, they have responsibilities, and this allows for these three members to check and balance one another. The difference between entering an order, or for example, writing an order, and activating an order must be made clear to all members of the team. Entering or prescribing is the job of the physician and is the same as writing an order. These orders must include the 5 drug rights, and additionally, with the high-risk medications such as chemotherapy, the order should also include special considerations for that patient. For example, are there any treatment parameters? Are there any monitoring guidelines? Are there pre-medications, rescue medications, and any dose modifications? Once that information has been obtained by pharmacy, they can then acknowledge that their own safety verification process has been completed, and they can then signify to nursing that that order is able to be activated. The nurse taking care of the patient uses his or her clinical judgment for activating an order. A nurse should wait until they see a patient, they do a brief and focused assessment, and they then activate the order, signifying to the pharmacy that they are ready for the chemotherapy drug to be mixed and then administered. That allows us to be prudent with how we give chemotherapy and make sure we're only giving it to the patients that are able to safely tolerate that medication day in and day out. In addition, with this threefold system, we really need to bring in more safety checks in the electronic setting of how we actually document things. For the administering chemotherapy, there must be an independent verification by 2 chemotherapy certified nurses, and they must each document that they have confirmed the patient's weight for the dose of chemotherapy they are receiving, presence of a completed and current consent, as well as any dose modifications and the route that the drug is being given in. When we use 2 independent nurses to check off these different safety areas, we are able to decrease harmful events and near misses, and also improve workflow and minimize delays. In addition to our safety checks between the 2 nurses, we must include hard stops into our electronic record, and this will be done at the point of contact for a patient as they are getting their chemotherapy. When we use electronic hard stops, we are seeing a computer being used directly at the chairside or bedside where the chemotherapy is being delivered. Once the nurses have verified the patient's name and medical record number, they also re-verify the 5 drug rights and must document it in real time in front of the patients. If they are unable to, or if they have a missing step, then a hard stop, such as this yellow exclamation point, would pop up and saying like, you are missing information. You may not exit out of this page until you complete all of the areas and all the fields in its entirety. And that way the nurse can say like, oh, we really forgot to mention rate. We are going to give this medication over 30 minutes. The rate will be 200 mLs per hour. And that adds an extra technological reminder and assurance that all of these high-risk medications are being handled in the best and safest way possible for our patients. Of course, with any change, we need to consider finances. There's every hospital has a bottom line, and it comes down to money. We are a business, and we want to make sure that what we are doing is cost effective for our health system, so that we can continue to give the best care possible to our patients. Not only must we consider the actual cost of getting new software, builders, informatics specialists, but there's also going to be a hidden cost, and that is the cost of time. It takes time to train new people, to give them the education of using new software, using new formats, new ways of getting and exchanging information. But that's not to say that that cost doesn't come with a really strong return benefit as electronic charting becomes more comprehensive and we think in the long term. The documentation reflects the actual care being provided, which in turn allows the billing department to better capture care, treatments, and other interventions, and that in turn creates more revenue for the hospital. And this is just one snippet from one of the very popular electronic health record providers. One of our customers just increased revenue by 20% through our EHR implementation, and that is because more information is being captured, and more information is now billable. And that is a huge incentive to a hospital because of resource utilization. There are a number of things that we need to measure when we make a change, because we want to make sure that change has a positive effect that affects both safety and quality. The benefit of using electronic records is that there's an increase in the data entry that is actually going into that can then later be pulled to help measure certain outcomes. For example, in the ambulatory care center here, we would want to measure adverse drug reactions, chemotherapy reactions, an independent verification of high-risk dose, verification of patients using 2 unique identifiers. This data can all be pulled. It can be plotted out on a timeline, and it can be used to show how are we as a unit or as a department coming up to snuff with the institutional goals, such as having a decreased wait time or better overall throughput. With the electronics on our side, we can use the information, we can pull it, we can educate our staff and show where we need to have improvements. Patients, there are several outcomes that are going to be patient specific, and there's a couple that are also going to be nursing specific. First and foremost is the reduction of medication errors, and that of course is specifically going to be with regards to chemotherapy and biotherapy infusions. These are very high-risk medications, and they come with very severe adverse events if they are given incorrectly or at the wrong rate or at the wrong dose based on patient's body surface area. Direct harm to the patient is a result of the wrong dose of these types of medications. And as this diagram kind of breaks it down for us, we can see that prescribing, administration, transcribing, and dispensing all contribute to errors in medications. And with a more sophisticated electronic health record, we are addressing every single aspect of how medication errors happen. Another patient-specific outcome is to decrease delays in care, such as wait times for clinic appointments and treatments. Delays can be measured by showing the difference in the time of check-in to the time of patient entering their chemotherapy chair in the infusion room. Compared to medication errors, wait times might seem like somewhat of a harmless error or a harmless nuisance even, but the research out there shows quite the opposite. In fact, with long wait times, the impact on the patient experience is reflected very negatively. Patients describe long waits as the worst part of their clinic visit, as devastating to their mental well-being, and even that it increases their pain and their anxiety. And as we care for cancer patients and we are helping them through this process, whatever we can do to take away indirect harm, such as extensively long wait times, is something that we should absolutely be doing. Nursing specific outcomes would include a few things, and the first would be compliance for the using 2 unique patient identifiers during the administration of high-risk medications. In the case of Massey Cancer Center, we use name and medical record number, and also the compliance of our safety check by 2 independent chemotherapy certified nurses. Both of these nursing-specific parameters can be measured using data that is pulled from the electronic health record, as I stated previously. And that data retrieval is fast, it's provided in real time, and it can be measured over a specific period of time. Nurse leaders can even use compliance rate for individual nurses as a source to guide, to mentor, and to provide feedback on performance, and so that we can all strive to increase our safety culture. In order for a change such as dynamic as switching from paper to electronic and helping to kind of work over this fragmented system, it's going to be really an uphill battle. This type of change can be met with much confusion and resistance by end users, and those are those nurses that are using the technology while caring for patients simultaneously. Therefore, we present an added challenge of balancing how we care for a patient in a compassionate manner and not allowing technology to become a barrier between ourselves and the patient. Nursing leaders can support an acceptance of this new use of technology by giving our nurses enough time, enough education, and allowing dedicated training for these nurses, meaning if there is a nurse that is struggling, they should be able to get one-on-one time with a nursing informatics specialist so they can really dive deep into what is a barrier to them using this new technology. In addition to time and education and training, transparent leadership is going to be a huge key with how nurse leaders focus this change and help to roll it out in a safe manner that increases quality for our patients. Nurse leaders, hospital administrators, and boards of directors must exemplify this safety culture through transparency and systematic improvements. Additionally, there needs to be a non-punitive system for reporting errors. When errors are found, that is information that everyone must know about so that they can all prevent future errors from happening. And we do not want to seek retribution for errors reporting. We want to improve that process and we want to welcome it so that we can find where are there holes in this system and where can we fix it. As this diagram shows us, transparency and diversity of ideas and openness, they all foster and reinforce one another, and that's what transparency and leadership is all about. In summary, healthcare systems in this modern day must really keep up with rapid changes coming from many different sources, such as healthcare policy, changes in technology, and transition of moving patients more and more from the inpatient environment to the outpatient setting faster and faster and faster. To keep up with these changes, healthcare systems really need to start adapting quickly and developing processes that can keep up with the current needs of the patients. As hospitals form strategic plans, quality and safety needs are at the forefront of every new initiative, and each change that is instituted must always be inclusive of patient-centered care. When you keep the patient at the focus of your change, quality and safety will always follow. I thank you greatly for your time today, and I hope you found this presentation informative, and I hope that we move forward with these changes and that they continue to improve our patients' outcomes. Thank you very much.